Kaladar, you can make
Yeah.
yourself available.
Yes, sir.
Sir, we are good to go.
Okay. Yeah. Good evening, everyone. This is Dr. Kaladar. So, welcome to Tuesday's webinar sessions from the Department of Critical Care Medicine, Yashoda Hospitals. We bring forth these classes regularly, very interesting topics and latest advancements that are happening across the department, across the critical care medicine field. And these interesting topics will be discussed by our senior and very expert clinicians. So today's topic of discussion is controversies in sepsis and ARDS. To discuss this topic, we are honored to call upon our distinguished speaker, Dr. Jose Chacko, sir. I can say sir has contributed significantly to the critical care medicine field, and listening to his lectures is really very interesting, and sir simplifies it, and his approach and his presentation is very much capturing. And I want to highlight one more thing is sir has significantly contributed to the field through his blog, which is called Chacko's Critical Care Blog Spot, which is being discussed various topics of critical care, and along with different trials, the landmark trials, which are very handy, and most of the times I go through those things and learn a lot from those from that blog itself. So without further this thing, I welcome you on board, sir. Please, you can proceed with the presentation, sir. And Dr. Venkat Raman Kola, sir, is here with us. So sir is actually traveling. That is the reason I took over. Otherwise, sir is the one who regularly does this session. Sir, Venkat, sir, do you want to comment anything? Not audible, sir.
It's muted.
Sir, unmute, sir.
Over
You're muted.
to you, Chacko. Over to you.
Thanks, Dr. Kalada. Thanks, Dr. Kola. So I'll just share my screen. I hope my screen is
Yes, sir.
visible to you all.
Yes, sir. It is full screen, sir. Yeah, we are
Okay.
able.
Yeah. Thank you. So tonight we will deal with a few of the controversies that have evoked a lot of interest in the field of critical care medicine over the last many years. Talking about controversies, there is none that would match the controversy associated with steroid use, to begin with, in sepsis and septic shock. The use of corticosteroids in septic shock is by no means new. In fact, it captivated the interest of clinicians dating back to the late 1970s, when the dose that they used was mega doses of methylprednisolone, like we do with pulse methylpred these days. So they used, similar to pulse methylpred, high doses, short period of 3 to 5 days, and predictably, as we know today, the results were quite disastrous. In fact, the mortality was higher with the use of corticosteroids in sepsis than compared to patients who did not receive steroids. So there were two studies that actually looked at this. The Bone et al. Trial and the Veterans trial, both of which used mega doses of methylpred and came up with negative findings. And because of these initial negative findings, the use of steroids slowly faded away over the next couple of decades until the 1990s, when we had small trials which used what they described as more physiological doses of hydrocortisone in contrast with the mega doses of methylpred that the earlier studies used. So they used more like the doses that we use today of hydrocortisone. And there were a couple of small trials that showed that the blood pressure improved, and there was a trend towards improved survival as well, although the sample size in those early studies was not really large enough to come to any conclusion in terms of clinical outcomes. So if you look at corticosteroids, at least on a physiological basis, there is a lot of positive benefit that you might accrue from the use of corticosteroids. It is anti-cytokine. It increases the response to vasopressors. It inhibits neutrophil aggregation, one of the key physiological aspects of sepsis. And it increases the SVR and reduces the synthesis of vasodilators. So all these mechanisms you would normally expect to be beneficial in patients with a vasodilated state, as in sepsis. So after these initial studies, the first large randomized controlled trial was by Anain et al. Almost 22 years ago in 2002, wherein they compared a combination of hydrocortisone and fludrocortisone, which is a mineralocorticoid. They used these two in combination, compared it with placebo, and they found the survival, 28-day survival, was higher in patients who received the combination of hydrocortisone and fludrocortisone. And the mortality benefit was particularly evident in those who had reduced response to the corticotrophin stimulation test, which they did in this particular study. So patients who could not mount a normal adrenergic response, as in stress-related release of cortisol, they benefited much more. The survival was better in this particular study. Later on, we had the Corticus trial, roughly 5-6 years later. They did not use mineralocorticoid, they just used hydrocortisone. But in contrast to the Anain trial, they did not find any difference in survival at 28 days. Against the background of both these studies, we had in 2018, just 6 years ago, the Venkat et al. Trial from the AND6 group in Australia, which was called the adrenal trial, in which they used hydrocortisone alone. They used a continuous infusion of 200 milligrams per day for a duration of 1 week. So in this study, they found that the 90-day mortality was similar between hydrocortisone and placebo. However, they observed earlier shock resolution, which was seen in most of the studies with hydrocortisone use in the past. They also found that mechanical ventilation was discontinued earlier with the use of corticosteroid. So was ICU discharge among patients who received hydrocortisone. So this was a signal that even though corticosteroids, hydrocortisone in a dose of 200 milligrams per day as an infusion may not improve survival, there are several other clinical benefits, including earlier resolution of shock and a reduced duration of mechanical ventilation. And subsequently, we had another couple of trials published, the Approaches and Hypres, among which the Approaches trial revealed a reduced 90-day mortality with corticosteroids, the same combination that Anain used 22 years ago, hydrocortisone with fludrocortisone. So he found a reduced mortality with this combination with the Approaches trial as well. So the current consensus and current guideline recommendations suggest the use of low-dose hydrocortisone in patients with septic shock and severe sepsis. So that's what I believe most of us do follow in the current clinical scenario. Sorry. Now let us look at the use of hydrocortisone or corticosteroids in community-acquired pneumonias. So sepsis, of course, we had some good evidence starting from the early 1990s that the use of corticosteroids in physiological doses might benefit. How about corticosteroid use in community-acquired pneumonias? The use of corticosteroids for community-acquired pneumonias captured interest with the study by Confalionieri et al. That was more than 2 decades ago, in which his team showed in a randomized controlled trial that the use of hydrocortisone in community-acquired pneumonia was associated with improved survival. Although this study was a very small sample size, which could not really be taken as robust evidence that hydrocortisone improved survival in community-acquired pneumonia. Very recently, the Cape Cod trial was published, which promises to be a turning point with the use of hydrocortisone in severe community-acquired pneumonia. So this study was conducted in France, the Cape Cod trial. In fact, they started recruiting patients more than 5-6 years ago. And then in the middle of the study, COVID pandemic swept across the world and in France as well. And at that time, they had to suspend the study. And later on, they went on to terminate the study at that level. So by the time they had nearly 800 patients randomized, 400 to hydrocortisone, 395 to placebo, and they found fairly conclusive evidence to suggest that the 28-day mortality was lower with hydrocortisone treated patients. So was the 90-day mortality, and there was a trend towards reduced intubation rates and reduced use of vasopressors with hydrocortisone. So the Cape Cod trial, which was one of the first large randomized controlled trials to show a positive benefit in terms of improved survival with the use of hydrocortisone in community-acquired pneumonia. However, there are a few caveats to this study, one of which is the ESCAPE trial, which was conducted by Umberto Meduri's team. Meduri, as you may be aware, is one of the top proponents of the use of corticosteroids in ARDS and community-acquired pneumonia. So his team conducted the ESCAPE trial, and they published it in Intensive Care Medicine around the same time as the Cape Cod trial. But they, in contrast to the Cape Cod trial, did not find any benefit with methylpred in this case. They used methylpred compared to hydrocortisone in the Cape Cod trial. So there are, as I mentioned, a few preconditions that may have to be met before we embark upon the use of corticosteroids in community-acquired pneumonia. These may include the type of steroid. We have good evidence that hydrocortisone may be more efficacious compared to methylpred if you go by the ESCAPE trial. Then, of course, an important question regarding the duration of treatment. What is ideal duration is not easy to answer. Cape Cod used it for 8 to 14 days, while ESCAPE used it for slightly longer, 20 days. More severe pneumonias may benefit more than milder cases would, at least on the face of it, it looks like that. And there may be differences between the response in viral versus bacterial pneumonia. We know that the recovery trial and the REMAP-CAP trial very clearly showed the benefit of steroid use in COVID-19. Recovery trial was the first to come up with their results, and the subsequent trials actually were terminated given the positive findings of the recovery trial. So viral versus bacterial is another question. In fact, the Cape Cod trial did not really differentiate the extent to which they investigated their patients to figure out the etiology was left to the clinicians. So not all patients underwent exhaustive testing to figure out the underlying etiology. So it was a mixed population of viral, bacterial, and so on. They showed benefit, but then the question remains unanswered whether steroids may be more beneficial in viral compared to bacterial pneumonias. And would the efficacy depend on the pathogen involved? Would the use of biomarkers guide us in appropriately using steroid as well as timing the use of steroids in community-acquired pneumonia? Is another question that needs to be answered, perhaps in future trials. Subgroups of patients who may benefit will still be a little bit unclear, considering that all RCTs have uniformly not come up with the same answers. The most credible study so far is, of course, the Cape Cod trial. And it's important to remember, be it in sepsis or be it in pneumonia, most of the studies which used conventional, normal, smallish doses of corticosteroids have not shown much of adverse effects, particularly in terms of nosocomial infection, gastrointestinal bleed, and so on. Hyperglycemia has been observed in many studies, but the real bad adverse effects, as in an increase in incidence of nosocomial sepsis or gastrointestinal bleed, have not been demonstrated in most of the studies. So you might conclude that on the balance, if you're in doubt, you could probably administer steroids without having to subject your patient to the risk of nosocomial sepsis and GI bleed. So just to sum up the use of corticosteroids overall in patients with community-acquired pneumonia, in sepsis, you would most certainly use, if there is pneumonia and sepsis, you would almost always use corticosteroids. ARDS and pneumonia may be a good reason to commence steroids. Viral pneumonias, as in COVID-19, may be another good indication to start corticosteroids in community-acquired pneumonias. And these days, we have ready access to multiplex PCR, which might help us guide the use of steroids better. The third indication for steroids over the years in ICUs have been its use in ARDS. And this is one area in which we are not very sure. ARDS not primarily related to pneumonias. ARDS, say, secondary to extrapulmonary causes like trauma, extrapulmonary infection, and so on. Would steroids be indicated in ARDS in this situation? The Lazarus trial was conducted more than 2 decades ago, which compared the mortality among patients who were treated with methylpred and placebo. And in fact, in this study, they could not find any difference in the 60-day mortality, 180-day mortality, or ventilator-free days in this particular trial among patients with severe ARDS who were treated with methylprednisolone. But there were 2 studies by Meduri et al. First one was a small sample study of just 24 patients. And the second study was a much larger one, which indeed showed benefit with what he suggested at that time was early use of corticosteroids in ARDS and prolonged treatment for up to 21 to 28 days. So he continues to suggest that early use of corticosteroid, don't wait for the fibrotic changes to happen. Earlier dosing and for a longer duration, 3 to 4 weeks, may be beneficial according to these studies. So this question is still unanswered. I personally do not have any particular opinion. You need to individualize based on the circumstances you face with each patient and come to a rational decision. If your patient continues to remain on ventilation, severely hypoxic, not much improvement after the first 3 to 4 days, then you might seriously consider the use of corticosteroids. Late use of corticosteroids in ARDS may not only be not beneficial, it may also be harmful. We would briefly deal with recruitment maneuvers in mechanically ventilated patients with ARDS. So the the ARDS-NET trial recommended titration of PEEP based on the FiO2 alone. So that may not be the way to go, because recruitment is something that you would apply if you believe there is recruitable lung. If there is lung that can be opened up with increase in the level of PEEP, you would certainly try to increase the level of PEEP. But if the lung is solid, if the lung is so much consolidated that there is no hope of opening up closed alveoli, there would be no point in trying recruitment. It might actually cause harm. In fact, none of the studies, be it any of these, ART, EXPRESS, and FARLAB, which were the three cardinal studies that looked at high versus low levels of PEEP, none of them demonstrated positive benefit in a mixed cohort of patient with ARDS with increased PEEP compared to more conventional levels of PEEP. And in one of the studies, FARLAB, in fact, they had to modify their study protocol halfway through, because when they tried recruitment with high ventilation pressures, a couple of their patients suffered cardiac arrest. So that is a possible harmful effect when you try recruitment in patients who have non-recruitable lungs, particularly. So one of the methods that we have been doing in the past few years has been bedside ultrasonography. By gradually increasing the level of PEEP, as you can see in this particular image, you can see most of the basal lung is consolidated at 5 of PEEP. When you increase the PEEP to 10, you get more recruitment on this particular image. And as we increase the PEEP to 15, there is much more recruitment. Most of the lung is actually recruited. So I would like to just underline the importance of assessing recruitability. If the lung is not recruitable, it's best not to increase the levels of PEEP to very high levels. The convention has been to assess recruitability going by the compliance alone. If compliance improves with increased PEEP, you assume it is recruitable lung. But then that may not always be the case. And that's when bedside ultrasonography, as you see again here, might help you to decide whether incremental levels of PEEP would actually result in lung recruitment and improved oxygenation. It is worth studying to particularly assess clinical outcomes. Bedside ultrasonography as a modality of assessing recruitability. The next, one of the most important questions that again creates some controversy and the status is a little bit unclear, is the use of neuromuscular blockade during the first few days of mechanical ventilation in ARDS. But thankfully, we have two good studies now which have specifically tried to answer this question. There are several theoretical advantages with the use of neuromuscular blockade in the early phase of ARDS, during the early phase of mechanical ventilation. It prevents asynchrony, reduces inflammatory mediators, reduces the work of breathing, gives you a free hand to try recruitment maneuvers, increase the levels of PEEP. It reduces pendulift, which is back and forth movement of air within the lung. These are the advantages. And on the other hand, there are disadvantages, of course. If you use it for too long, you might get persisting neuromuscular weakness. It might delay weaning. Lack of mobility for a long period of time makes your patients prone to get DVTs. Ocular complications may occur if the eye is unprotected, and these patients also require deep sedation. So all these are potential disadvantages with the use of neuromuscular blockers. So what's the evidence today that we have to evaluate the use of neuromuscular blockade in severe ARDS? There are two studies that stand out. This study, 2010, Pepetzian et al. Accurasis, which I'm sure familiar with. They studied 340 patients with a cisatricurium bolus and infusion in the treatment arm, placebo in the control arm. and they found on adjusted analysis, there was a reduction in the 90-day mortality with the use of cisatricurium for the first 48 hours. And the ventilator-free days were also more at 28 and 90 days with cisatricurium. However, 9 years later, in 2019, the ROSE trial was published, which followed almost a very similar protocol, cisatricurium in the treatment arm and placebo in the control arm. But they could not find a difference in mortality at 90 days, nor in the ventilator-free days, nor in the ICU-free days. So these studies seem to be at contrast with each other. However, there were a few points that deserve mention as to why these studies, although they used a very similar design, came up with contrasting results. First was that the ROSE trial was stopped prematurely for futility, and they did not achieve the sample size, which may have resulted in an underpowered study. Second was that the ROSE trial did not prone their patients as much as the Accurasis trial did. So proning, as we all know, goes a long way, at least in improvement of oxygenation in the early phase of ARDS. So that might change outcomes, improve outcomes, as we know from the Presiva trial. So the use of prone was lower in the ROSE trial compared to Accurasis, which might explain the difference in outcomes. PEEP, the level of PEEP used in the ROSE trial was higher, which is likely to have improved outcomes without the use of too much of neuromuscular blockade. So that may also compromise the results. And the ROSE trial was unblinded in contrast to the Accurasis trial, because as you know, lack of blinding may lead to bias. Next, we go on to the target map in sepsis. There has been one study that has really been a cornerstone, you would call, a proper randomized controlled trial in patients with septic shock, wherein they compared a blood pressure of 80 to 85, mean arterial pressure, as the high target and 65 to 75 as the low target. And across the board, they did not find any difference in the 28-day mortality, although they found some difference in outcomes on subgroup analysis among patients with hypertension. They benefited with a slightly higher mean arterial pressure. That's not a very strong finding to go by. So all this study would suggest to us is aiming for a map of more than 65 to 70 may not be required in most clinical situations. Talking about blood pressure and supporting blood pressure, what are the catecholamines that you would use? We know from history there has been several studies which question the use of dopamine, which at one time was a first-line vasopressor in patient with septic shock. We are talking about sometime in the early 1990s to even early 2000s. But then came the ANSIX study on dopamine versus noradrenaline, and they found not only did they find no benefit with the use of dopamine, there was no benefit on renal function, contrary to what the physiologists might think. And the clinical outcomes were also no better with dopamine compared to noradrenaline. And subsequently as well, we had the SOAP trial, which showed increased mortality with dopamine. And DeBacker trial again, which showed noradrenaline to be superior to dopamine, even in patients with cardiogenic shock. So currently, the vasopressor of choice, the recommendation by the surviving sepsis guidelines as well, is strongly in favor of noradrenaline. So noradrenaline is perhaps the way to go. One of the, you won't call it new by no means, methylene blue has been around for a very long time. In fact, one of the early studies I remember was back in 2001 or so, more than 2 decades ago, wherein they used methylene blue versus placebo in a small randomized controlled trial, and they found that shock reversal was earlier when they use methylene blue compared to not using. And there were some studies after that in patients with vasoplegic shock after cardiopulmonary bypass. This is actually reasonably common after cardiopulmonary bypass. They become severely vasoplegic and they become resistant to commonly used vasopressors, including noradrenaline and vasopressin. And in this particular refractory vasoplegia, methylene blue has often been tried as a rescue agent to preserve the vascular tone. But today, we have a randomized controlled trial, not a very big trial, just 91 patients, that compared methylene blue with control in patients with septic shock. So in this particular study, they designed the study in such a way that they used methylene blue right from the beginning. In addition to noradrenaline, they would use methylene blue as well. Methylene blue was used in a dose of 100 milligrams per day, run over a 4-hour infusion for 3 consecutive days. So 100 milligrams per day over 4 hours for 3 consecutive days. And in addition, they continued with the other vasopressors, whatever they would use. So they found that first, the time to vasopressor discontinuation was shorter with methylene blue, 69 hours versus 94 hours. So that was the median time, obviously shorter duration of vasopressors in those who received methylene blue. The number of vasopressor-free days was also longer among those who received methylene blue, 23 versus 19 days. And among the other outcomes, they found ICU length of stay and hospital length of stay to be shorter in methylene blue treated patients. But do remember that this was a very small randomized controlled trial, certainly not powered to assess mortality. The only finding you could say was that they could stop the vasopressors earlier, stop the other vasopressors earlier, and the number of vasopressor-free days was also longer in the methylene blue treated patients. So it is methylene blue has come back to be of interest these days, but by no means do we have what can be described as robust evidence. There is some preliminary evidence that suggests that it might support blood pressure in severely vasoplegic patients better than the conventional vasopressors. But does that translate to improved clinical outcomes is something we need to evaluate in future randomized controlled trials. The use of lactate as guide to resuscitation has been studied over the years. But then the big question is, should we titrate resuscitation to lactate levels? There are problems associated with the use of lactate in this situation. There is no question that high lactate levels is very bad in patients with sepsis, and it carries a high mortality. That's very true. But there are two things that's worth remembering. First of all, the lactate levels may not rise in the early phase of sepsis, may or may not. On the other hand, paradoxically, it may be an early finding in septic shock, even if the blood pressure is okay. So it is not very reliable as an early predictor of shock, first. Second is titrating resuscitation to normalize lactate levels may not be appropriate, as the Andromeda shock trial very clearly showed us, because lactate levels may not return back to baseline even if your resuscitation has been adequate enough. So if you keep on resuscitating with bolus after bolus, bottle after bottle of ringer lactate or normal saline, you might end up overloading your patients inadvertently, might lead to considerable harm. So do remember that lactate levels do indicate a bad outcome, but you should be careful with titration of resuscitation to normalize lactate levels. That by no means would be the way to go. At least if you see a downward trend in the lactate levels, that may be good enough. You need not carry on with resuscitation to normalize lactate levels. That may be going far too overboard, particularly relevant in patients with sepsis, because lactate levels in sepsis is quite often not because of dysoxia or hypoxia. It is merely as a result of accelerated glycolysis and a hypermetabolic state, and also relative deficiency of pyruvate dehydrogenase. So that results in the lactate levels being high, even without any evidence of tissue hypoxia. And of course, this lactate is used as a metabolic fuel through oxidation and conversion to pyruvate in the liver. So it is not a bad substrate as such. It is used up by the liver, but then it does indicate that you have a patient with severe shock in your hands. So the use of lactate levels as an endpoint for resuscitation is not appropriate, but do recognize the fact that hypoperfusion-related hyperlactatemia is an important parameter to go by, and you should not keep on resuscitating to get the lactate levels back to normal. So I would just briefly summarize what we went through already. Steroids certainly indicated in septic shock. There is no evidence of any harm with the use of steroids, and possible benefit, if not in mortality, at least in the duration of ventilation. Community-acquired pneumonia, severe pneumonia, sepsis, septic shock, steroids may be appropriate to use. Then ARDS, we are not entirely sure, but if your patient is in dire straits, it might not be harmful. Recruitment maneuvers you should be careful with, particularly high levels of PEEP, and ultrasonography may be a good way to assess recruitability of the lung. Neuromuscular blockade, we would go by the Accurasis trial, and I think most of us would prefer to use neuromuscular blockade in the first 2 or 3 days. Target map, no need to aim for high levels, 65 to 70 would be good enough. And methylene blue may require more investigation in terms of evaluating clinical outcomes, although it's been shown to improve blood pressure and reduce the duration of vasopressor support. Thank you.
Thank you, sir. Thank you very much, sir. Really, it was very interesting presentation. Could learn very good points from that.
Just a moment, I'll just switch on my power. The battery is down, just a moment.
Okay, sir.
Okay, we can continue.
Yes, sir. Nice presentation, sir. It was really very good, covering very good points. Could learn some very good points from the sepsis and even the ARDS point of view. Interesting burning topics, I can say. And regarding the questions, sir, the questions which were posed from the audience are, as you were stressing on, like recent evidence Cape Cod study, so which showed the benefit, especially in the patients who are community acquired pneumonia. But in that study, they excluded influenza pneumonia, and most of the studies have given the result that especially in H1N1 pneumonia, they were harmful, and some patients even landed up in pneumonias, those who were used the steroids were used in those patients. As compared to the recovery and remap study of the COVID, where they were shown to be improving in this case of moderate to severe ARDS. So even though both are viruses and the pathophysiology may seem same, why the conflicting results in both of these types? How to go forward, sir? Like,
yeah, you have pointed out the difference in outcomes in H1N1 and COVID. I think one of the things that you perhaps would need to consider is that the trials with steroid use in H1N1 were very small, and most of them were retrospective studies. And I think there was only one really good randomized controlled trial. Even that was of a smaller sample size. And after the 2009 epidemic of H1N1, we haven't had a big enough epidemic to study the use of corticosteroids specifically, I feel. So the lack of beneficial effect that with corticosteroids in H1N1 may not be real. If you do a large enough study with large enough sample size, we might see benefit, is what I feel. Because as you pointed out, viral pneumonias do tend to show benefit with the use of corticosteroids, as we have seen very clearly with COVID-19 in the recovery and the REMAP-CAP trials. So it is an open question. We are not sure at this time because there has been no large enough RCT like the recovery trial with COVID-19 that has assessed efficacy of corticosteroids in H1N1.
Yes, sir. Yes, sir, that's true. So probably I think more larger studies may throw it, right? Because we are seeing more and more patients of H1N1 pneumonia. Uh, Probably those who are very severe ARDS, still we can try. So how do
Yeah.
you think, is there any difference between the type of steroids, sir? Because the recovery trial and all, they tried dexamethasone. Some people use methylprednisolone. Some people, yeah, hydrocortisone prefer. Do you think any difference in terms of choosing steroid type?
I don't think there is any evidence, if you go by the available evidence, to choose the type of steroid, be it dexamethasone, be it methylpred or hydrocortisone. But the Cape Cod trial, of course, they used hydrocortisone. So that is something that we can go by. Recovery used dexamethasone, of course, mainly because it was more easy to acquire in that particular scenario. There was large numbers of patients, easy availability, cheap, easy to use. That's the main reason that drove them to use dexamethasone. But there has been no comparison. I don't think there will be a study that compares different steroid preparations. So I suppose equivalent doses of any type of steroid, be it methylpred, hydrocortisone, or dexamethasone, may not make a difference. That's my own intuitive feeling.
Yes, sir. Yes, sir. So regarding the septic shock and steroids and the septic shock, sir. So most of the studies have shown that the vasopressor free days are much better. The hemodynamics is getting better, much good result rather than the outcome benefit. If you look at like the Anand trial and all, where some studies used only hydrocortisone, some studies used hydrocortisone plus fludrocortisone. Do you think we have to use both of the drugs, or otherwise only straightforward one hydrocortisone is enough? What do you think, Venkat?
The adrenal trial, which is the largest, of course, they use just hydrocortisone, 200 milligrams per day as a continuous infusion. May not be the ideal way to do it. And infusion may not be the ideal way because the main reason being, if you don't give a bolus dose, particularly at the start, the blood levels may rise very slowly. That may not be appropriate. Anyway, that's the way they used it in the largest trial. The Anand trial of 2002 and the Approaches trial later on, they used a combination of hydrocortisone and fludrocortisone. So most of these studies in the later half of this decade have confined to hydrocortisone. And even the Approaches trial, if you look at that trial, they started recruiting patients a very long time ago, I think almost 15 years ago, because they used it in combination with dotricogen alpha or recombinant factor 7 alpha at that time. And halfway through, they stopped recombinant factor 7 alpha as well. So that was a very old trial. Most of the patients were recruited a very long time ago. So whatever good evidence we have today from large trials, they haven't actually used mineralocorticoid as in fludrocortisone. The Corticus trial did not use. The adrenal trial did not use. So I would stick to just hydrocortisone. That's been our practice at least.
Yes, sir. Yes, sir. Regarding one interesting concept, as you were telling, like which has to be, I can say, regularly practiced, ultrasound guided PEEP strategy, sir. So that was very interesting. So, what do you think, sir, regarding the recruitment maneuvers using at the bedside, the patient who is desaturating even on the 100% FiO2, and most of the recruitment maneuvers have shown that the benefit is not good, harmful
Yeah.
effects are there.
Yeah.
So, but in a crisis situation where do you think we can use recruitment maneuvers for a brief period and then probably?
Yeah, the classical recruitment maneuver is the application of a constant inflation pressure of 40 to 50 for about 30 to 40 seconds. You do essentially an inspiratory hold at a high pressure. But many studies have shown that this may not be a good thing to do, particularly in terms of the hemodynamic instability that it may cause, and also in terms of the barotrauma, pneumothorax that it might cause. In fact, as I mentioned, the ARDS study using a very aggressive recruitment maneuver had to actually abandon their tactics or re-modify their technique halfway through the study. So instead of using this sustained inflation method, what we have been using, particularly with ultrasound guidance, it is gradual step up in the level of the applied PEEP from 5 to 10 to 15, perhaps even higher. At each level, you wait for 10 to 15 minutes, and that gives you enough time to look at the lung, to look at those areas of the lung which were collapsed, see if they're actually opening up or not, which you can see very clearly with ultrasonography. And if it seems to result in recruitment, you carry on with it, you hold on to the high level of PEEP. But if it does not show, if it doesn't budge at all, as we see in many cases as well, if that doesn't show any improvement with an increase in level of PEEP, then there is no point in trying it because the lung essentially is not recruitable in that situation. So that's the way I would go. I would just go by gradual step up of the PEEP level and probably not use a sustained inflation maneuver as a recruitment maneuver.
Yes, sir. Yes, sir. Thank you, sir. So, regarding the hemodynamics point of view, as you were telling, sir, uh, the targets of mean arterial pressure in septic shock. So, SEPSIPAM and study initially like showed that the target has to be 65 initially. Once we target that and we achieve, suppose the shock is getting better, do you think is there any at later stages? Do you think is there any difference between the background hypertensive patients with compared to normotensive patients? We have to have any different targets and look at any acute kidney injury, or probably most of the times they land up in acute kidney injury, but whether any urine output is coming, whether we have to target that, how to go
Yeah, should you maintain the MAP levels higher in patients who are hypertensive at baseline? It's a very important question, but unfortunately, we don't have any clear-cut answers. We just go by a standard number, 65 to 70 is what the sepsis spam trial suggested. We go by that. And if you look at the evidence, it's hardly any evidence to suggest that you should aim for higher levels in hypertensive patients. But then again, I suppose you wouldn't go entirely by mean arterial pressure alone. You would certainly go by other features of circulatory circulatory parameters, including the urine output, assuming that your patient is not anuric already, including the acid-base status, how does it go, including the lactate levels as well, the capillary refill time. Perhaps these are all other circulatory parameters that you would consider in the titration of your mean arterial pressure level. So just to give a completely blanket answer will not really be possible based on the evidence we have. We may need to adjust the target blood pressure based on the baseline blood pressure of your patients but then it is a decision that has to be individualized, and there are nothing to suggest from the evidence that we have so far.
Yes, sir. Yes, sir. Regarding vasopressors of choice, sir, as you were discussing about methylene blue, uh, uh, we had like angiotensin 2 also in between, but of course not much available in India. So what do you think, sir? Suppose if it is there available, do you think is it a better vasopressor?
It
And
needs to be studied. I think most of the vasopressors that have been tried out have all increased the blood pressure, but then blood pressure is not the only outcome that you look for. You need pretty firm evidence to suggest improved clinical outcomes. Do they survive better? Do they survive with less acute kidney injury? So all these things, all these parameters are important clinical outcomes that need to be assessed. Unfortunately, after that single trial with angiotensin 2, which showed improved blood pressure, we haven't had any trials that looked at clinical outcomes. So that's the reason why you may use, there are several vasopressors available to us. Which is better? We still do not know unless you do a proper comparative study. Till that time, I suppose norepinephrine is generally recommended. Not that there is any strong evidence to suggest that it's much superior to any other vasopressor, but then that's something time tested and supported by whatever little evidence we have and also by guidelines.
yes, sir. Regarding methylene blue, sir, most of the people nowadays there is conflict of interest when we start. Some people will go start. Some people say no, no, it causes more harm than useful. Some people say bolus will give, and some straight away start with the infusion. So suppose if we want to choose methylene blue, what are the subset of patients you recommend, and how to start the infusion and all, sir?
I think it is worth doing a study like the Mexican study, which I already alluded to,
Yes.
wherein they used a fixed dose of 100 milligrams over 4 hours given for 3 consecutive days. I think as a strategy, that sounds like a good strategy. But then, of course, they had only 91 patients in their study, not really enough to assess clinical outcomes. They demonstrated improved blood pressure, reduced vasopressor use, all that is fine. But the bottom line is, does it really improve clinical outcomes? And this really needs to be investigated. We have used methylene blue in refractory septic shock on the odd occasion, but then that is nothing to go by really, just a handful of patients. And most of them were in refractory hypotension and they wouldn't have survived in any case. And our cardiac surgery department also occasionally used methylene blue in refractory vasoplegia. So apart from these anecdotes, we really don't have any concrete evidence to support the use of methylene blue. But I think that's something that perhaps is worthwhile studying, because the putative mechanism, which is by inhibition of nitric oxide, that's a mechanism by which methylene blue works. That is the basic problem in sepsis. And assuming that is a basic problem, and if you have a mechanism to inhibit this induced nitric oxide and the associated vasoplegia, that might turn out to be clinically beneficial as well. But then, as I mentioned, we need to do large studies. One of the problems with methylene blue, you won't be able to blind the study because the urine color will turn blue, and even the mucosal surfaces will turn blue after some time. So it may be very difficult to blind a study with methylene blue. That will add bias probably.
Yes, sir. Yes, sir. That's true. So the questions from audience are like, what is the role of vitamin C and thiamine in that HAT trial and all? Yeah. So
Yeah.
your comments on that, sir?
Vitamin C and thiamine
Thiamine.
was proposed some time ago in a retrospective study. But then subsequently, we had a randomized control trial as well, which did not show any benefit with megadoses of vitamin C, thiamine,
Yes.
hydrocortisone combination. So at this point of time, you wouldn't particularly support the use of vitamin C, thiamine, unless if you feel your patient is deficient in these vitamins.
Other questions, sir, like hydrocortisone, if we use in septic shock, how many days generally we use? What is the target, the duration?
The duration is for the period of hemodynamic instability. Usually 5 to 7 days is the maximum. And then depending on the duration of treatment, you might taper it down and stop, or even abruptly stop if it's only for 3 to 4 days.
Yes, sir. So another question, I think is asked, like methylene blue does it work in pulmonary hypertension? Will it have a pulmonary vasodilator effect? Don't think.
I do not know.
Yes, sir.
Don't think so.
Don't think so. Yes, sir. So I think all the questions been answered, sir.
Okay.
Okay, sir. Thank you very much, sir.
Okay,
Any
then.
final comments
Thanks a
from you,
lot.
sir?
No, that's it. Apart from the fact that it's important to rely on evidence. You can carry out research on your own, but then when it boils down to bedside practice, you need to go by the evidence we have and also by your own personal experience. Based on that, you individualize care on your patient. So individualization based on the clinical circumstance is also important.
Yes, sir. Yes, sir. Thank you very much, sir. It was really very interesting session and enjoyed thoroughly, sir. Thank you very much.
Thanks a lot. Thanks a lot, Dr. Galada. Thanks,
Yeah.
everyone.
Good night, sir. Take care.
Good night. Bye.
Good night, all.
Thank you, sir. Thank you.
Thank you, sir. Thank you all.